I'll open it up to questions. I'm looking at Richard, but oh, good. See, not a shy crowd.
Okay, what is the current thinking on the NBUVB treatment if you have a lot of moles, not cancerous moles?
Sure. So NBUVB, which is narrow band UVB. So if you have lots of moles, but they're totally okay moles, then I still put patients on narrowband UVB. When you look at the studies as far as risk of skin cancer for narrowband UVB versus PUVA, which is the other type of light therapy we use, PUVA therapy definitely has an increased risk in mostly squamous cells, but also for melanoma. But for narrowband, I would, as long as I'm monitoring the moles and they look okay, I would go ahead and start because I think it's a great treatment option for early stage, especially patch and thin plaque MF. If you had a melanoma, then an invasive melanoma, then I would stop. But there hasn't been anything that's shown that that actually increases your risk of melanoma. Not actually even basal cell or squamous cells. So the studies, if the risk is there, it's exceedingly low. The studies, I think the best ones are really in psoriasis, where they looked at studies of over 3,000 patients, and they haven't detected an actual risk of basal cell or squamous cell skin cancer. The only time they found it is in patients that were actually treated with something else that already increased their risk.
Great. Always good questions. More questions? You raise your hand. One over here.
Do you advise using both UVB plus steroids or protopic for stage 1B MF?
I'm a purist, I don't, but you may feel differently.
So combination of narrowband UVB and topical steroids? Yes. Well, I do because sometimes the narrowband doesn't shine in every location. So where the light doesn't go, it can't really treat. And so we have what are called the sanctuary sites. So oftentimes there's an area in the groin or an armpit that the patient can't hold their arm up long enough to get the light in the armpit, that I do use some topical steroids too in those areas.
Can you briefly tell us the difference between PUVA and narrow band?
Okay, so ultraviolet light, when we think of it, there's UVA and UVB. UVA light penetrates deeper in the skin than UVB. So narrowband UVB is one wavelength of light that penetrates through the epidermis into the top layer of the dermis. So for people who have their lymphoma that's all in the top layer of the skin, it works great. But if you have very thick plaques, the light just can't get as deep as it needs to get to the lymphocytes. So then we usually think about switching to UVA light that travels deeper, therefore works a little bit better, especially if it's in hair follicles. We need that extra depth, or if they're thick plaques. The P of PUVA is actually for psoralen, which is PSORLEN. And the psoralen makes the UVA light act even stronger. So it gets in, you take the medicine about 60 to 90 minutes beforehand, it gets incorporated into the cells, and then the light treatment works even better. So narrowband is usually if it's thinner patches, plaques, and then progressing to PUVA more for thicker plaques or follicular tropic involvement.
Good questions. More questions. Oh, here we go.
Can you explain the PCR reactions and what you're looking for?
Okay, I have to say I have a bias about gene rearrangement. I don't use it, but the concept of it's very interesting. So each lymphocyte, when it creates a lymphoma, it has a very specific target, some of which we don't know what the target is, but it's a clone. So when you look at all the lymphocytes to see what is their target, when something's, in theory, a clone, you would see a big spike in one area, like you were showing the red cells, that there's too many of one cell hitting a certain target. The problem is just as described, though. Sometimes people have a clone, they don't have a cancer. And sometimes people do have a cancer and they don't have a detectable clone. So in my practice, I don't use it at all, pretty much, because it doesn't add, in my mind, too much to the diagnosis, because in the end, the pathologist has to see the cells and they have to look correctly under a microscope, or you don't have the diagnosis. So in the end, we got to go back to, at least currently, to looking at the cells under a microscope, and they have to look a certain way. But you'll see, sometimes it's very confusing to patients. I get patients all the time, just as you mentioned, where somebody has done gene rearrangement and it's positive, and they tell the person they have lymphoma. And then I get to tell them, no, you don't. It's kind of fun, but it's a waste of a visit. Similarly, somebody could see that their gene rearrangement is negative and they've been told that they have a lymphoma, and that becomes very confusing also. So, you know, I would tend to minimize the focus on that particular test. You know, again, might feel different.
No, similar. I think it has to just be taken with a grain of salt. And I think there are certain situations where I find that it's helpful, and that's when we're trying to make the decision, is it lymphoma or not? And the pathology is kind of gray, and the skin exam is a little confusing. And when we have multiple biopsies from multiple sites over time. So one visit you biopsied the thigh, the next visit you biopsied the hip. And when I find the same clone in both of those biopsies, that is helpful for me to say that pushes me a little bit more towards it being lymphoma, but it's definitely not black and white. Some people do a lot of testing of clonality on the blood. I don't find that helpful. So really, mostly when we're doing it, it's because the case isn't already clear black-white, and it gives us one other push in one direction or the other, especially if we have matching clones. But ultimately, you have to start with atypical lymphocytes from the get-go. And I have had the same situation of patients who come in with a positive clone, and I say, you have pityriasis lichenoides chronica. You don't have MF. You have a totally different benign rash that sometimes has a clone, and it's pink and scaly, so it can be confusing. So it does sometimes cause a lot of stress and anxiety, and you wouldn't have ordered it if you'd seen them ahead of time.
I have to say, I actually do use it in blood.
Oh, really?
So yeah, go figure. So I might use it in the setting of giving, I've been using it a lot, giving mogamulizumab to make sure somebody's really in a complete response before I stop the drug.
So, and a lot of different options, right?
Yeah.
As the technology gets better and better, right? This is new technology that we haven't really had before. So we're still learning.
I couldn't resist. I'm always one with a question. This checkpoint inhibitor, pembrolizumab,
Yes.
vis-a-vis getting long-term ECP, which Joy knows about, which is there a difference? Because both are boosting the immune system.
There's a
So-
huge difference.
Yeah,
They have a totally different mechanism.
That's the question. What is the mechanism?
Well, nobody exactly knows the mechanism of ECP, but there's some purported thoughts about it. But it has nothing to do with PD-1 inhibition. It's a totally different. The immune system is very complex. So there's a number of ways that you can enhance the immune system that have nothing to do with one another. So ECP, in theory, enhances the immune system in a totally different way by recognizing antigens on the cell surface, and is infinitely less toxic than a PD-1 inhibitor.
And I think it gets confusing, right, with all the different names and types, and we're getting more and more new treatments.
What are the results of the Cova Morrison clinical trial at this moment? Is it very successful?
Well, the results have been published. It's very promising, and it will go forward, hopefully with a drug approval. Unfortunately, when we look at things in the mycosis fungoides space, to another oncologist looking at it, none of our drugs look very good. They're always about a response rate of like 30 to 40%. Right. And yet they all really help people. And if you hit the right drug, then it's 100% for you. And so by the general standards in the lymphoma world, where we're used to talking about complete remissions and they're 90%, all of our results look very poor. But you know, despite the fact that that most of our drugs, not light or putting nitrogen mustard on your skin, which does have a very high response rate. Most of our systemic drugs, when studied, have relatively low response rates in the whole oncology world. They still are extremely useful. Yeah.
So this feels like a real newbie question, so forgive me. But with regards to follicular B cell, could you explain or talk about the difference between slow growing and aggressive as it relates to reoccurrence? So if it's a slow growing type, but it comes back very quickly after clean scans, does that automatically mean it's become aggressive? So
That's a great question. So slow growing really relates to the cell itself. So I'll give you an example of 2 skin lymphomas. When somebody has cutaneous B cell lymphoma and it's follicular center lymphoma, the lesion can stay there. It won't change much in size over very long periods of time, months, years sometimes. Whereas if somebody has leg-type diffuse large B-cell lymphoma, they can see their lesion growing weekly. So the kinetics of the disease is very, very different. And the relapse has nothing to do with the growth rate. So it just turns out that people that have cutaneous B-cell lymphoma relapse very frequently in skin. It doesn't impact their prognosis at all. It's really, it's just kind of the natural history and the nature of the condition. And I would have to say that scans wouldn't be the way I would be following a skin lymphoma, but you would know by the way it looks on your own skin. So relapses have much more to do with the natural history of the disease, I think. I don't know if you would, yeah. Okay.
Excuse me, I have 2 questions. Is cutaneous lymphoma hereditary? And is it people with certain blood types more prone to it, like type O positive, or? That's my question.
Yeah, lymphomas in general are not considered hereditary disorders, but there's about 10% of people with lymphoma, all types of lymphoma, where there's other family members with lymphoma in the family. We haven't identified why that is, but there are certainly families that have too many lymphomas in them. So it's an area of interest, but it doesn't affect the majority of people. And that's so funny about the blood type. Somebody was asking me that the other day, and we were looking through the literature. There's a couple of really old articles, like 60s, 70s vintage, that talk about blood types with certain kinds of cancers, but I don't think people pay too much attention to that anymore. That was just all they had to look at then.
Hi, I have 2 quick questions. One is are any of these diseases diurnal? In which do they have a clock? Do they tend to be more active in the evening, or are they just daylight neutral?
What do you mean by active?
Well, I mean, I have a significant itch, but I itch.
Okay, that's what I thought you were getting at.
I itch much more at night than I do during the day, and maybe that's because I don't pay attention during the day.
That's right. It's not that they're more active. It's the same thing with pain. It's always worse at night. And our brains are interesting machines. So if you give the brain a different stimulus, it'll forget that you have itching or pain. That's how most anti-itch things work, at least the ones that you put on your skin, is by giving your brain a different stimulus so that it goes, oh, there's cool something on the skin. I kind of forget about the itching. So it happens a lot at night because there's not much else for you to pay attention to. It's not that the cells are more active, though. It has more to do with the nerve pathways that conduct things like itching and pain.
And the other question is that the cure for everything these days is CBD oil.
It certainly is.
And is there any reason to think that it's helpful, not helpful?
It might relax people.
Conflicting.
It might be a good emollient. You know, like a good oil.
Generally, as an emollient, as it's been recommended to me.
It might be a good form of oil, though you could probably go in your cupboard and get vegetable oil and it'd be the same thing.
Oh, so Wesson oil is just as good as coconut oil.
Yeah.
And a lot cheaper.
Or olive oil, all of it. Baby oil.
Thank you.
For people with the early stage mycosis fungoides, they say only about 10% will progress. And I understand that they're doing studies to see if they can figure out that who will progress and who will not.
It's probably not even, it's not 10%. I'm not sure where you got that number from, but there's a very old landmark study from Stanford that looks at people with 1A disease, and only 2% of them progressed. And you could kind of pick out who they were because they developed tumors, they didn't respond to their treatments, they tend to be older. This is very old data. So the progression rate is actually quite a bit less than 10% for somebody with early stage disease.
Maybe I can induce a cage match fight, but hem-onc versus dermatology. And I know there's some intersection, but some people get treated by oncologists and some strictly by dermatologists. Just a comment about that?
Yeah, we get this question every single time. And I was waiting, and that's why I set you up. But basically, that's why I said we have very similar database. I'm actually appointed in the derm department too. You need to go to somebody that knows this disease. It doesn't matter if they're dermatology or oncology. My dermatology friends know about all kinds of systemic things that regular dermatologists don't know. And I, weirdly enough, know all about things like light therapy and how skin rashes look that I shouldn't know, that most internists wouldn't know. So in the end, I don't think it matters who you got, but you got to have somebody that knows this.
Yeah. And so you probably do more derm than I do onc because I work with an oncologist. And so we do a multidisciplinary clinic. So we go into the room together. And I think it's just a matter of that whatever they do, that's what they do regularly and often. And they're used to going through all of the explanations, whether it's a 2-person team or a 1-person team who just has all the experience.
Okay, I have a couple from the home audience. Richard, I'll come back to you in a sec. Let's see. We're trying to do this in the best way possible. Someone says Imiquimod made their heart race. I don't know if that's a side effect of that particular arena, so probably not.
Can make you feel like you have the flu.
Yeah.
That I've definitely.
If you put a lot of it on, it can also irritate your skin, which might make your heart race.
Okay. All right. Go ahead, and then I have one more.
Okay. The other day actually 3 days ago, I went to Ask the Doctor with Jacob Sumarai from Mass General. And he said that Matthew John Frigalt was working with CAR T cells. And they were looking at a trial and that I should talk to Jeffrey Barnes. Can you expound on the CAR T cells?
In general? Or his particular trial?
Or is there a trial coming up that we should all be looking at?
Mostly what I've seen is the target would be CD30 is the furthest along. Has everybody heard about CAR T cells? It's another thing that's kind of been in the news. Yeah. All right. It's more complicated than you think. So what's described in the news is you take, and it's true, you take somebody's lymphocytes out, you put them in a laboratory at a company or an institution, you alter them to change what they're going to hit. T cells are our immune system. You give them back to the patient, they go after the target. It sounds so simple, right? Everybody says, I want to take my cells, I want them re-injected and engineered. But there's a huge learning curve here. So again, when the immune system gets revved up, it's not a pretty sight sometimes. So when you inject these cells, first of all, you have to get chemotherapy to allow you to accept them. When you get the cells, they can cause something called cytokine release syndrome. It can be deadly if somebody isn't treated properly. It's a big storm of the immune system where the person could have a fever, their blood pressure could drop, on and on. And there are also some neurologic complications, which aren't as well defined, and someone could end up in a coma. So these are fascinating things to do. Where they've been approved is in diffuse large B-cell lymphoma. They're extremely important ideas because they allow a third of people that would have no other treatment option to probably be cured. So it's extremely important, but it's not to be taken lightly at all. And we have a long ways to go to figure this technology out, although it will be figured out. how to deliver it to people safely and who to give it to.
Okay, we have a question from Australia,
Okay.
which is probably of interest. So I'm going to try to paraphrase because it's very long. But husband and wife both have had different ethnicities and have been diagnosed with cutaneous B-cell lymphomas at different points in time. Wondering if there is a connection. They may have had some exposures to chemicals over the years. Would that be a possibility, or is it just potential synchronicity that it's a tough question, and I don't know that we have any answers, but wanted to.
Well, we
Get in a
though
thought.
people are very interested in what causes increased risk of B-cell lymphomas, period. There are very few agents in the environment that are truly accepted. One being Agent Orange. They weren't in this country, so probably weren't
Probably not.
exposed to that. And other than that, I'm trying to think what a couple would have: hepatitis B or
No.
C, HIV. I mean,
been Borrelia and marginal zone that's in, but
yeah.
Or no,
It's hard to think of something that two people would have had exposure to that
unless
where
it
you
was
could link it.
man-made chemicals.
or some infectious agents,
Yeah.
viruses or
Mm.
some bacteria. I can't really think of it because the other things that create an increased risk of lymphoma are often things that you were born with, immune alterations. That's all I can think of.
Okay.
It's a
Great.
stretch.
Oh, one more question, and then we're going to take a break.
We're all being like zapped by a radar in the Navy.
Yeah, nobody's heard about radon and lymphomas. It's been of more interest in lung cancer.
Okay.
All right.
Okay.
We're going to take a break. Thank you both very much for that very informative and helpful session.